When I put on this about yesterday about kinematic imbalances due to suboccipital strain, it was great. One of our German friends immediately got back to me and says, do you still use that term over in the UK? And I said, yeah, I do, because it's very useful, because it covers a whole range of issues, and there's quite a lot of research evidence about it. So it's a good one to put in for your diagnosis or your clinical impression or whatever, because it covers a range of things. But for me, a KISS1 syndrome, and I said this to him, is a rotary upper cervical subluxation, and a KISS2 syndrome is a bilateral AS subluxation. But those are what things that occur very commonly, and we see regularly in practice. So I thought it was a really nice thing to look at and cover. One of the big things is, why do we see KISS syndrome? Why do we get babies with these kind of issues? And primary is birth trauma. What is that? It's basically any condition that adversely affects the fetus during delivery. And the classic thing is, it's either too fast a delivery, too slow a delivery, or the baby's in a funky position during the delivery process. Those are the sort of major things. Of major birth trauma, the incidence is sort of 3 to 9%. And these are things like cuts, where they've been a bit too enthusiastic with the scalpel, brachial plexus lesions, fractures, organ ruptures, the really nasty stuff. And that's 3 to 9%, so it's quite high. More recent studies quoting 25 to per 1,000 births. So there's quite a lot of those serious stuff, but there's a lot of this which is much less common, much more common but less serious type of injuries. And if we look at the predisposing factors for these sort of birth injuries, what will your patients say happen to their child or happen during the birth process? And the classic things are artificial oxytocin, syntocin being used during the birth process. So induction. Induction increases stress during the process. And the quote down here at the bottom, induction of labor at term is associated with adverse outcomes. It's not great if you can avoid it, but they induce a lot of people these days because we've got so many older mums, and they won't let the mums go too long because of that. We'll look at malpresentation. If they're in a funky position, if they're upside down or sideways or whatever, that's going to create an issue. Multiple pregnancies, always an issue with that. One baby at least is in a bad position. Prolonged labor, just there too long. Baby stuck in that birth canal. Going through the birth canal has a really positive effect on the baby, provided it's not there for an excessive period of time. So it can be very good, but it needs to not be there, stuck there for 18 hours in the birth canal, obviously. Particularly a prolonged second stage, that's where the mum is pushing and there's the greatest pressure. Epidural anesthesia is linked with it as well, because the mum doesn't know what she's pushing into, etc. Forceps delivery, something's gone wrong if you need a forceps delivery, so things aren't going well. Shoulder dystocia, if a shoulder gets jammed, it's usually with a supine delivery, and we try and steer our pregnant mums away from that, and excessively big heads, although they are a rarity. So what is the trauma? Trauma to the bony, our cartilaginous skeleton, skull fractures, nasal trauma, we see these quite regularly. Trauma to vascular tissue, fluid dynamics, things like cephal hematomas. And I'm going to tell you, with cephal hematomas, there is between 11 and 24% association for depressed skull fracture under a cephal hematoma. So you need to be able to recognize one of those, particularly with a very young baby, and know that you need to treat it as if there is a depressed skull fracture underneath it. Trauma to nervous tissue, brachial plexus injury, Erb's palsies. Soft tissues, torticollis, so bleed into the SCM, lump in the SCM, which we see, or asphyxia, and that's one of the commonest causes of birth issues with cerebral palsy and that kind of thing coming from it. But major birth injuries are in the main obvious and receive early diagnosis and treatment. And we've already talked about those, but lots of others don't, and they don't get noted. These are the ones who come into our practice most commonly. And Gottlieb in a 93 paper, with excellent paper, said birth trauma is an underpublicized and therefore undertreated problem, which indeed it is. And we are the ones who are dealing with a lot of it in our practice. So when we say, well, KISS syndrome, what is a KISS syndrome and why is it there? KISS syndrome is basically a baby with its head in a funky position. Okay, and we're going to do the comparison between KISS1 and KISS2. Okay, so the baby is either going to be laterally flexed and rotated, or extended, particularly in sleep, so with the head in extension. And why is it like that? Well, can you imagine that it probably got like that in the birth canal, where it was laterally flexed during the birth process, or just during the end of pregnancy, it was constrained, it was in the wrong position. Or if it was a face presentation, it's going to create that extension of the skull, extension of the neck, creating that compression there. So Heine Biedermann, when he looked at this, when he did the research on this, he found that prolonged labor, 3 times more common to have a KISS syndrome, multiple fetuses, and instrumental delivery. Lots of the reasons we talked about for why do these kids get these issues. And why do they have these problems? If you look at this frontal angle here, so we've got our atlas and your occiput there, you see this frontal angle between those guys coming through there of those joints is very open, is very shallow. This leaves the area vulnerable to trauma. And there's a lack of really restriction of motion in there. The baby hasn't got much ability, oh, there goes an ear thing. The baby hasn't got much ability to react to its environment, to change its head position. It's got very little head control, lack of muscular fixation, and a lack of neuromotor control. So that's where the KISS syndrome becomes an issue. And here we have a very, very typical KISS syndrome. Babies, and you'll see them in there, they're usually brought in their horrible car seats, and we can talk about car seats, but I'm not going to get me going on that. It's one of my pet hates. But they're brought in car seats. They're okay in the car, but not in the rest of the time. And then you see the baby laterally flexed and rotated, and that's the position it's in. Now, one of the things I always ask the mums is the baby's head normally in that position? And very often they say, yeah, isn't it cute? No, it's pathological is usually an answer I give, which is maybe going a little bit far, but it gets the mum's attention. It's not good to have them with what we call positional preference. Okay, these kids will exhibit positional preference. They will go into this position because that's the position they're comfortable in. Okay, and so they have a fixed lateral flexion. A torticollis. A torticollis is literally a lateral flexion rotation kind of issue, and that can be there for lots of reasons, ranging from a bleed in the SCM to a KISS1 syndrome to Sandifer syndrome, which is reflux, right up to a posterior fossa tumor. There were lots of reasons for these, but the most common that we see is actually probably a KISS syndrome, creating that issue. And if they get that, they will lie with their head, as you can see with this little infant, lying on really what we call the plate area, which is the junction between the occiput, the temporal, and the parietal. And that area will flatten into what we call a plate shape. And they will get skull asymmetry from that. And these kids, you can see this scoliotic posture in this little baby. Whoops, sorry. Let me go back to that one. You see that scoliotic posture which is developing. The commonest cause I've seen of infantile scoliosis is these abnormal head positions from upper cervical subluxation problems that create these issues. And you can get following that gluteal asymmetry and asymmetry of motion of the limbs. The baby will tend to look and move this side and will tend to progressively ignore this side, which is a real issue with those things. And so we'll get retardation of motor development on one side. If they get that, can you think about what might develop over the longer term? Because the baby, sure, the baby in 6, 9, 10 months will be able to move its head, even if without treatment, but it's going to be favoring this side. And if it favors that side, you're going to get much higher levels of your dyslexia, your dyspraxia, even your ADHD and those kind of things, because they've developed primarily one side of the brain more than the other. Okay, and we can get very detailed into that, but we won't at the moment. But Biedermann talks about it a little bit in what's called a KIDS syndrome. So they're very common. KISS1 we see a lot of. A lot of the babies coming into your clinic will exhibit this positional preference, and it's a strong indicator of an upper cervical subluxation complex. The KISS2 markers, this is Harry, this is the little boy. This is taken about 2006 when I finally worked out how to fix a KISS2 syndrome, which I didn't know. And yeah, despite the fact that I'd practiced Gonstead for my first few years in practice, and this is a classic Gonstead bilateral AS occiput. That occiput is slid up and under, okay? And this is where they will sleep. This is him asleep, where he would sleep with his occiput touching his thoracic spine. Really, really nasty, nasty thing. They are not as common as KISS1, but they are bad news. they'll tend to get occipital flattening, often asymmetric. The shoulders tend to be pulled up, supination, fixed supination of the arms, lack of normal motion of the arms some of the time. They hate front time. They hate being on their front. They don't lift their trunk up very well because all this sort of development of extensor tone has gone wrong in them. Oral facial hypertonia, so they won't move their mouth as well, so they'll tend to get breastfeeding difficulties, but they'll have breastfeeding difficulty on one side. Now, I think, this is from kind of Biedermann's work, I personally think breastfeeding difficulty on one side is just as common in KISS 1. I see it regularly. And for me, it's a pathognomonic marker of an upper cervical skull-based issue. They can't feed on one side well, they feed on the other well. The most likely, there can be other things, but the most likely is that they've got some sort of upper cervical problem that we need to look at taking care of. So there's our KISS 1 and KISS 2. Now, Heine Biedermann talks about the KISS to kid thing, which is a really interesting thing where he describes children of 4 to 6 years of age who suffer from KISS syndrome in what he describes as KISS-induced dyskinesia, spatial disorientation, dyskinesia, and dyspraxia, the sort of lack of normal developmental motion, developmental coordination disorder, kid syndrome, when not corrected when young. And this can be, because there is literature on this, this can be parents' fears when you describe their kid's got a KISS syndrome. But one of the things we're going to say is, well, if we're treating this when young, we're going to try and make sure this doesn't happen. What we also see in children these days is a massive amount of MSK, musculoskeletal pain in childhood. There really are significant proportion of children who have back pain, who have neck pain, who have all those kind of things. And for me, a lot of this can be a sequela to these kind of things. If you start off wonky, then your whole system is going to develop in an asymmetric pattern, and then you're more likely to get dysfunctional movement patterns and therefore pain, which is, I think, a common thing we're seeing in children going through to adulthood. Good news is it'll keep us busy for the rest of our careers, guys, but you know, it is something, if we can tackle it early, here's much the better. So there we've got the two postural asymmetries. I've put them together from a KISS 1, showing you that lateral flexion and rotation there, creating that sort of torticollis and that postural asymmetry with it. And then you've got the KISS 2 with that full extension. So they say KISS 1 way more common than KISS 2. But if you're going to spend the first few months of your life in these kind of positions, do you think that might affect your brain development? Do you think that might affect your longer term outcomes? My answer would be very, very strongly. You're going to be firing up very much one side of the brain with this KISS 1 issue. And that's what we want to try and avoid. So the more we can get these kids in with postural asymmetry and treat them, the better. So what do we do about it? Well, one of the things we're going to look at is doing a KISS 1 correction. So we assess a baby. Here I've got this baby actually sat in the crook of my leg. So I make a figure 4 with the leg. So instead of crossing my legs normally, I put my ankle onto my opposite knee, and then the baby's bottom can sit in that little hollow made by that. And you can make that bigger or smaller depending on the baby's size. I'm just going to escape from full screen here and end share as I try and show you this thing. So what we're doing with this baby, okay, is the baby sat down there, okay, we're stabilizing the top of its head. Don't cover its eyes, it'll hate you for that. It likes to see what's going on. So you get someone playing with some keys or something in front of it, and we can do a P to A glide. So you see my fingers either side there, okay, finger and thumb, bridge contact, laminar pedicle junction, and I'm just going to glide this in a P to A direction, okay, C1, C2, C3, so on down the cervical spine. Now the classic thing is with these babies of limited rotation, it will normally be in the C1-2 complex, you'll find it, and you'll find one side just does not glide. Okay, well that's the one we need to adjust. Now, I'm not suggesting you adjust them immediately without doing a full examination and a full neuro exam and all that. We're assuming you've done that and you've come up with the fact that this is a typical KISS 1 syndrome, upper cervical subluxation. So we're now into the adjustment phase. We're going to take a hold on that. So we've got a C1 on the left, left, doesn't rotate back, doesn't go forwards when I press it. So in a moment it will. So I'm going to hold pressure P to A on C1. I'm going to stabilize the opposite side, but I'm not going to use any pressure with my thumb. The pressure is P to A. The pressure I'm going to use on a newborn baby is the same as I'd tolerate on my eyeball. So if you're pressing more than you tolerate in your eyeball, that's way too much. So we hold that in a P to A. We hold that for between 5 to 8 seconds. So we go through the muscular barrier to the ligamentous barrier. At the ligamentous barrier, if we're happy, we can access a little fast stretch. And it's a tiny, tiny little motion. It summates the stretch, and we get the fast stretch receptors as well as slow stretch receptors. That is the sort of most useful way of doing it. That's a C1 correction. If it was a C2, I'd do exactly the same with C2. So hold for a count of 5 to 8 with steady pressure. The baby will not stay still, it'll tend to move its head. That's great. You just hold that pressure in them. This is a direct correction in that direction, and then you can add a fast stretch. You don't have to. Okay, and you only do that if your skill set is appropriate to do at that time. If you have that skill set, then great, do it. Okay, I'm just trying to get back onto full screen. Okay, so I need to go into share, sorry. Messing this up. Okay, so where's my share screen? There we go. And so we're back on. There we go. Okay, so that's what we do. So don't worry about doing the fast stretch initially. You can use it as a slow stretch as well. Okay. The KISS 2 correction, well, this is one it took me years to work out. These babies I struggled with. I did all kinds of upper cervical corrections to them and everything like that, and got some better and some not so much. And then I realized this, if we just go back to the principles of Gonstead, this baby, because it had been a face presentation, had that occiput had been forced forward with a relationship to the C0, C1 joint. Okay, it was a bilateral AS occiput. So what we want to do with that bilateral AS occiput is get a bilateral contact on the occiput. Okay, so fingers under the occiput as much as you can, thumbs up onto the forehead, and then we do a gentle traction with the fingers and with little pressure down with the thumbs. Again, guys, it's eyeball pressure, no more than eyeball pressure. Holding that steady pressure, how long for? 5 to 8 seconds, and if you're confident and you think you need to, you can add what is a tiny, tiny little fast stretch at the end, which stimulates the mechanoreceptors and the proprioceptors even more. Okay, but that is the way I've found to correct a KISS 2 syndrome, and it seems to work very well from using those Gonstead principles. Okay, so what happens with the fact that these babies, lots of these babies coming in, have massive amounts of gastrointestinal issues and other stuff when they're in this KISS 1 or 2 syndrome? Why is that? Well, because as soon as you start straining the upper cervical spine, you're going to strain the skull base. Your occiput is in 1, 2, 3, 4 parts at this time. Between the occiput and the temporal bone, so this is the petrous temporal here, there is this little hole, the jugular foramen, on either side there. These jugular foramen carry cranial nerves 9, 10, and 11 into your system. So cranial nerve 9, the muscles of deglutition, of swallowing. 10, your parasympathetic supply to your heart, lungs, and gut, right down to the distal part of your colon. And 11, the muscles to the SCM and upper trapezius, the nerve supply to the muscles of those muscles coming from that tiny little area. Also the blood vascular drainage of the cranium, 90% of it coming out those 2 little holes either side. So what we see with symptoms of these, difficulty in swallowing, choking while feeding, digestive difficulties, straining, constipation, reflux, colic, torticollis, all coming along with very often that positional preference and those KISS 1 syndromes because of those issues. Now, one of the things I'm going to say to you is if you're treating babies, and I know we've got lots of people who are very experienced in treating babies here, so I know I'm teaching you to suck eggs, but one of the things I'm going to say is make sure you assess and correct the sacrum every time. Whether you're doing just upper cervical work, please assess the sacrum. Things will go wrong if this isn't taken care of. We assess the sacrum by squeezing the buttock clefts together. We're looking for a deviation of the cleft. If the cleft is deviated, in this case to the baby's right, the baby has a right anterior sacrum. So we're going to stabilize the left ilium, the left posterior sacral side there, and I'm going to hold a steady pressure, P to A, on that posterior side, stabilizing here with my thumb anteriorly on the ASIS. So I'm holding that whole ilium complex and I'm pushing that sacrum anteriorly. How long? Getting boring now, guys, 5 to 8 seconds. And then we, if we want to, can add a fast stretch. You then recheck. Is that better? Great. But you need to make sure that the sacrum is capable of reciprocation with the cranium, capable of pumping. So what we're going to do is we're going to flare the ASISs. To do that, we squeeze together, we're going to flare the PSISs. To do that, we squeeze together the ASISs in the front, which flares open the SI joints, and then we're going to go base forward, apex forward, base forward, apex forward. A real kind of rusty hinge technique to pump that sacrum, get the CSF moving up towards the cranium. That is massively important. Please don't forget that when you're doing pediatrics, guys. Young babies, I'd go with anybody, but young babies particularly, get their sacrum moving. You'll stimulate the cranium and help that upper cervical subluxation patterns. So those will work, and there you can see I'm flexing, extending the sacrum on that baby to move that. Skull base, okay? Any of you saw the one I did for presentation I did for Chiro Chats? We looked at releasing the skull base. I'm going to just talk very briefly. Connor, I can see you online. Have I got about 5 minutes left? Okay, yeah, good. Okay, so that's I'll take that as a yes. Okay, so what we're going to do is we're going to check the occiput. Now, the whole point about cranial work is it's different from spinal work. Spinal work, you take it into the subluxation, you hold it in the direction it won't move, and then you can slow stretch it or add a fast stretch to it. With cranial work, we want to feel the restriction. And so when I'm feeling the restriction in the baby's occiput, my hands are under both sides. Okay, but I'm just going to show you my left hand because I need to hold the baby with the other one. And I'm going to flex it. I'm going to squeeze my fingers and the thenar together. And I'm feeling for pliability. Is the cranium flexible? Great. Compare this side to this side. That'll tell me whether the occiput is restricted. Often you'll find these, I mean really often in these babies who've got these kind of issues, really restricted. So what we do is instead of going into the restriction, pulling it that way, it's restricted, we're going to look into the direction of freedom. And what is that direction? I've no idea. It may be further down this way, it may be going laterally, it may be going medially, it may be going in a medial rotation, it may be going into lateral rotation. Whatever direction you can do, you follow it, follow it, follow it, follow it, follow it, until it stops the movement. Just follow that little tissue slide, we term it. Stop, right, another direction. Which other direction can it go? Follow that. You get 2 or 3 tissue slides and then recheck the occiput. You'll find that's much greater pliability. That is unlocking the area around that jugular foramen. So it's so, so important. Direction of freedom on that occiput. We can also do that on the temporal bones. These little guys here, okay, the ears, okay, the fascia from the ears attaches onto the temporal bones and all the way in to even the oscles of the ear. That fascia is attaching there. So way we can see, because if the temporal's been compressed in, the great way of getting a temporal compression, if you want to get one, is have a forceps delivery, where it's right over the temporal bone and they squish it in and hold it in there. That's going to compress your jugular foramen from the lateral border as well. So what we do to check that, and I'm not going to have a baby upside down on my shoulder, but it's just my way of trying to get it round. Here, I'm going to show you, actually, I can get the baby standing, there we go, with its on my chest. Let's get your hand down. Okay, so I'm going to pull the ear, so I'm getting my fingers deep into the ear canals as I can. I'm just going to pull laterally, and I'm feeling for lateral give. Is there lateral give? If it's, and you get used to this once you've done a few, and you'll feel it. If there isn't, we're going to go and find a direction which it will give. So it may go superior, may go inferior, may go anterior, may go posterior, may go in posterior rotation, may go in anterior rotation. We're just going to follow that round. And often You'll get one side going one way, one going the other way, and you little dance around those temporal bones. All the time you're getting led by the body. As soon as you come into a restriction, you run away from it and go into another direction. So, so important. Unwind, unwind, unwind. How long do they take me? About that long. Okay, so these releases are maybe 20, 30 seconds, maximum a minute. They are not going to take you very long, okay? And just trust what you feel, okay? The difficulty some chiropractors have is when they first come to cranial work that we're normally looking for restriction and then we go into the restriction. This is running away from restriction. So just run into the direction of freedom and you won't go wrong with it. And then we can recheck the pliability. And if you get those two released, you'll have released either side of that jugular foramen, which is just so massively important for the function of that area and all of those gastrointestinal kind of issues these babies tend to get. Okay, I think I'm done on this.